today's webinar is on vaccination for kidney patients, specifically on individuals on renal replacement therapy. And this webinar will be delivered by Dr. Victor Leon. Dr. Leon is an infectious disease physician and medical microbiologist. He is also a physician lead for antimicrobial stewardship and the medical director of infection prevention and control at Providence Healthcare. So with that, a couple of housekeeping rules. We are recording this webinar, and this recording will be available shortly after the webinar on the BC Renal YouTube channel. So please feel free to share it with your colleagues. It's going to be there indefinitely. You're welcome to send your questions through the chat or the Q&A throughout the presentation. The presentation will be about 15-20 minutes long, and then we'll have about 10 minutes for questions. So please feel free to send your questions in the meantime. And the only other thing is that in the meeting invite, there is a link to a BC Renal poster on vaccination to promote vaccination among patients. So you're welcome to access that and print that out and use it in your pharmacies, in your space where you see patients. It's available and free to use. Thank you so much. With that, Dr. Leon, I will pass it on to you.
Thank you. Okay, so hopefully the slides work now. So thank you for giving me the time to just provide a brief vaccination update for people with chronic kidney disease and those on renal replacement therapy. These are my disclosures, but for the event today, the content is I developed. So the objectives is to recognize the important role of pharmacists in vaccination health promotion, and to hopefully summarize briefly the clinical evidence for efficacy, safety of some vaccines, both vaccines that are all vaccines that are recommended by the National Committee on Vaccination in Canada. However, some of these vaccines, depending on the province where people are living and practicing, are not publicly funded by public health, even though the scientific data is there to make the recommendations. And the reason for that is because each province, there's the federal transfer of funding, and in each province, the vaccination programs are handled differently. In British Columbia, they are handled by BC CDC and Public Health. And then, so all the decisions that are made with which ones are going to be funded are going to be limited by what the government is willing to pay. So we know that vaccinations have saved a significant number of lives. This is from 1974 to 2024 in our world in data. And you can see that tops the vaccine that has saved the most lives, mainly because of its impact on reducing incidence and elimination of measles, thereby reducing the subsequent problems that develop after someone develops a measles infection, namely immunocompromise and immune amnesia, putting them at higher risk of developing other types of infections. So Canada now is at very high risk, and I believe it's going to happen, of losing measles elimination status that was previously achieved due to under vaccination. And a lot of that rhetoric is coming down from the south of us, and even in the United States, where vaccinations are not, where there's been a lot of narrative to decrease vaccinations. The president there has received his preventative annual influenza vaccine and updated COVID boosters, according to his physician. So we know that as an aging population, they are more susceptible to infectious diseases, and many of the medical conditions that they may have compound that risk. Concept of comorbidity stacking. Higher number of comorbidities, higher the risk. So when we look at vaccine efficacy numbers, just a quick reminder that a vaccine efficacy is evaluated based on clinical trials, and these are under ideal conditions. So randomized trials that look at the relative risk of whatever the outcome of interest is compared to those who did not receive the vaccine. So when you see a number of 80% vaccine efficacy in a trial, in a clinical trial, this means that those who are vaccinated are at 80% lower risk of developing the outcome than those who did not receive the vaccine. So I'm just going to highlight a few diseases that are, I think, quite relevant. One is Streptococcus pneumoniae. So a bacteria that we can't treat lightly because when it becomes invasive, it can cause severe disease. And we've had many patients come through the ICU with severe invasive pneumococcal disease, either involving the lung at first and then the bloodstream, with severe consequences when it involves the central nervous system. So the Prevnar or the pneumococcal vaccines in general are complicated, sometimes because of all the different ones that have been available over the years. But in general, we have conjugate vaccines and polysaccharide vaccines. We know that polysaccharide vaccines in general don't induce a T-cell response, whereas the conjugate vaccines do, thereby providing more durable response. So we can see that when we talk about the conjugate vaccines, we see the different numbers of PCV13 to PCV20, covering different serotypes of pneumococcal disease. And the challenge is that the surveillance systems we have in Canada are going to be behind, meaning that when we want to know today, what are the strains, what are the serotypes of pneumonia that are causing, or Streptococcus pneumonia that are causing invasive disease, we're always looking backwards. And so the predictability of which vaccines will provide the best coverage is not always easy. So we rely on the serotypes that cause the most invasive disease and which ones cover the highest number of serotypes. Bottom line is that in 2024, the recommendations from National Advisory Committee on Immunization in Canada provide strong recommendation that adults, any adult should have in the immunization program should have at least one of PCV20 or PCV21. Now that's a strong recommendation. There are also other strong recommendations focusing on the highest risk groups, adults who are 65 and older and those at increased risk of invasive pneumococcal disease. And we know that chronic kidney disease is one of those risk factors that is considered at increased risk. Again, they recommend one dose of one of these vaccines, regardless of previous vaccination history. And then we have special populations like stem cell transplant. However, as I mentioned at the beginning, British Columbia and other provinces don't have to follow that. This is a recommendation based on the scientific literature, but when it comes down to what they're able to fund, it comes down to what's available in the budget, the provincial budget. So in British Columbia, we have very specific criteria for what's funded. Even though the individuals who are in British Columbia with those risk factors listed by NACI should have the vaccine, they won't have it funded through the public health program. So in British Columbia, specifically for those with chronic kidney disease, the criteria is to administer PCV20 if not previously vaccinated with PCV21, or the polysaccharide PPV23 times 2 doses. So in the community, I guess I'd like to hear from you later on just about how easy it is to apply. But I can tell you from the hospital side, if the information is not there, we're just giving the vaccine. And that's the advice given by public health. So even though there were all these criteria established, in practice, because of our suboptimal vaccine registries and information systems, sometimes we don't have any of that previous vaccine information. So we can just provide the PCV20 in hospital. Now, for the next 2 vaccines, these are non-public health funded vaccines, but recommended. And I know that in community pharmacies, people may ask for them. Some specialized programs do cover it. This is a case I saw in hospital when I was on the internal medicine service a couple of weeks ago. It was a retired physician who had lots of comorbidities, all the cardiometabolic ones that you normally see. plus previous myocardial infarction and previous stroke. He went to Vancouver General Hospital in July with Bell's palsy, or paralysis of the facial nerve. Unfortunately, he was given steroids at a dose that was too high and for too long. For some medication ordering error, he received 70 milligrams of prednisone for 3 weeks. He returned to the hospital a week later with a vesicular rash on the thorax and became quite delirious. A lumbar puncture was done, and he was diagnosed with zoster, but a more severe complication of zoster known as encephalitis. So because of the reactivation of the varicella zoster virus, not only did it cause the dermatomal or the skin complications, he also developed encephalitis. I'll talk about the RSV complication after, but we have to be reminded that zoster is not just a rash. Recent publications, and a lot of this is showing us consistency, is that herpes zoster is a virus that can cause vascular inflammation and lots of inflammation that affects other organs. So for those with chronic kidney disease, it can accelerate the decline of kidney functions. For those with diabetes, it can destabilize diabetes. We now see increased risk of stroke as well as increased risk of heart attack after zoster infection. And more recently, consistent observational data showing the increased risks of dementia with zoster activation. So most of the time people think that it's going to be just a prodrome with a rash. Many people don't see the complications that happen after, which is the chronic phase. We know age is going to be the biggest risk factor. So of all the patients you see, the older they are, the higher their chance of getting zoster reactivation. And these are all the risk factors. So if we look at comorbidity stacking, or how many comorbidities an individual has, if we look at chronic kidney disease on the right, studies have shown that those with chronic kidney disease might be at 29% increased risk based on pooled risk ratios. However, most people with chronic kidney disease don't just have that as a comorbidity. They may have other comorbidities, some of which are non-modifiable. For example, age, diabetes, if it's poorly controlled, cardiovascular disease, other immunocompromising diseases, lupus, arthritis, and so forth. So all these diseases put people at various risks, but when they have more than one of these diseases, these risks compound. So from the observational studies, within 3 months of having a herpes zoster infection, the risk of cardiovascular events and cerebrovascular events is increased, but that cardiovascular risk is persistent up to 1 year post-infection, whereas the cerebrovascular or strokes decrease in risk after the first 3 months. So the vaccine that's available now, there's only one. So it's the recombinant zoster vaccine, or the adjuvanted vaccine. The adjuvanted components are 2 immunostimulants. This is given as a 2-dose vaccine, time 0, and then any point after 2 months. So generally 2 to 6 months. But if there's a delay, it doesn't need to be reboosted. So the protection from the zoster vaccine is durable. There's now 11 years of data that shows initially the high efficacy against herpes zoster in various age groups, but even up to 11 years, the efficacy stays pretty high. And that's why there's no recommendations to reboost. Now, if we go back to the case that I saw who lingered in hospital with encephalitis, the sequelae of encephalitis that this individual had led to significant functional compromise, mostly bedbound, not cognitively intact. So being in hospitals for several months, the day I took over, he had a positive RSV result that came back from the weekend. And so he acquired RSV, or respiratory syncytial virus, in hospital. For him, the initial week meant that there was increased productive cough and at times need for oxygen. he had a lower respiratory tract infection based on X-ray. Now, we might think that respiratory syncytial virus is a virus that comes and goes and that there's no sequelae, but we're learning a lot more about RSV, and the reason why RSV is one of the standard viruses that has surveillance now is because of the significant consequences. So I'm not going to focus too much on the pediatric side, but if we look at the older adult side, and population as a whole, the BC CDC has surveillance data. We see that RSV, which is in the top bottom left corner, has been mostly seasonal. We do have travelers who come in over the summer with RSV off cruise ships, but the incidence compared to influenza, for example, is not as high. However, we don't always test for RSV, depending on where the patient is when they present with symptoms. Even some hospitals don't standardly report out RSV if someone is being tested for a respiratory virus. So it may be an underreporting of the true incidence. If we look at older adults to the right, they differ than children in the left, in that those who are older 65 who have RSV, their attributable death and hospital-associated mortality is high, about 1 in 9. So for the individual I saw, even though he's survived his RSV infection, he's survived his zoster infection and zoster encephalitis, he's left with significant functional decline, and his chance of death being in hospital and having RSV is going to be significant. So this concept of comorbidity stacking applies to RSV as well. We see that individuals who have chronic diseases like asthma, CKD, COPD, if they have more than 2 chronic conditions in the blue, their adjusted rate ratios for RSV-associated hospitalization is increased. And that rate increases as well with age. So irrespective of the age group, this concept of comorbidity stacking problematic in terms of causing hospitalizations. Now, data from Ontario shows us that hospitalizations for acute myocardial infarction or exacerbation of heart failure, arrhythmias, and MI we already knew from the data it's high for influenza, and that's why it's so important to have annual influenza vaccinations. But for RSV, it's pretty significant as well. The incidence rate ratios of 3.51 with a large confidence interval based on the Ontario data, but still higher than other respiratory viruses. So in British Columbia, even though Canada has approved 3 vaccines, at a practical level, we have access to 2 because that's what's available. Now, these vaccines have not been compared in head-to-head trials, but they have been approved by Health Canada and NACI for these indications. So the adjuvanted RSV pre-F3 vaccine has the longest data, 3 seasons worth of data. It's indicated for prevention of lower respiratory tract disease caused by RSV in those who are 60 and older and adults who are 50 to 59 with increased risk. Whereas the other RSV pre-F non-adjuvanted vaccine is indicated for immunization to prevent lower respiratory tract disease in those 60 and older, but also in pregnant individuals who are 32 to 36 weeks gestational age. The role of that is to prevent lower respiratory tract disease and disease in infants from birth through 6 months of age. That would be particularly relevant to individuals who can't get access or don't qualify for passive immunity for the high risk groups for RSV. And that passive immunity is the antibodies, the nirsevimab antibodies. So the data, the vaccine efficacy data in season 1 for the adjuvanted vaccine is ranges between 82 to 94%, depending on the type of endpoint we're looking at, whether it's severe RSV, lower respiratory tract disease or any lower respiratory tract disease. We see that as across season 3, so 36 at 30.6 months, the vaccine efficacy declines a bit, but at this time there is no recommendation for a booster. Whereas the non-adjuvanted RSV vaccine has 2 seasons worth of data. You can see the vaccine efficacy numbers there. Just important to note that we can't compare these numbers between the vaccines because were not studied in the same clinical trial, and the definitions for lower respiratory tract disease were slightly different. So the NACI recommendations are that it should be targeted to any individual over 75 years of age, and particularly those at highest risk, and that's where we're going to see the highest value in return for investment in vaccination, whereas those over 60 years in nursing home also have important because of transmission in long-term care facilities. And then the discretionary recommendation, because there is less data on it in terms of the value of the vaccine in preventing hospitalizations, is those who are 60 to 74-year-olds. It's great that now many organizations have the same recommendations, so that we see, for example, for RSV, we have the global COPD guidelines, global asthma guidelines, American Diabetes Association, recently the American College of Cardiology, all recommending the vaccine for similar risk groups. And so in summary, for the herpes zoster and invasive pneumococcal disease, there is significant morbidity associated with the 2 viruses that don't have publicly funded vaccines, but it is available and should be at least brought to the attention of people who are at higher risk. And then for invasive pneumococcal disease, we do have a publicly funded program, and therefore should be cost should be not be a barrier for individuals receiving pneumococcal conjugate pneumococcal vaccine. However, sometimes the barrier might be if you have data that's well recorded and you show that your client has already received either they self-paid for conjugate 21 vaccine or they had the polysaccharide vaccine times 2 doses, then they wouldn't qualify for the public health funded vaccine. And then lastly, we didn't talk specifically about influenza and COVID, but I just wanted to make 2 points. The seasonal influenza vaccine uptake globally since COVID from year to year has gone down. We saw that with some of the COVID protection measures, transmission of influenza had declined significantly. And then with vaccine fatigue for some individuals and the changing narrative in the US, that has also severely impacted vaccination uptake. Usually we can predict what's going to happen in the Northern Hemisphere by what's happening in the Southern Hemisphere. And as of this year, Australia has had very high rates, one of the highest rates of influenza that they've ever recorded. And their vaccination rates have gone down significantly, irrespective of age group that they're looking at. So I think it's an important lesson we can learn from what's happened down south this season to have more proactive protection measures by encouraging and developing systems for influenza vaccination this year. And remember that the vaccine does take 2 weeks to become effective. The vaccine efficacy data so far, depending on which studies are out there you're looking at, is around 50%. And so that means that if those who are vaccinated are 50% less likely than those unvaccinated to develop influenza, and hopefully that can protect them from the complications of influenza, including hospitalization, pneumonias, and myocardial events, and all the other inflammatory factors associated with influenza infection. Similar for COVID-19, at least in British Columbia this year, compared to other provinces, we still have publicly funded vaccines, even though they prioritize to say that healthcare workers, for example, those living in long-term care, those comorbidities are at the highest risk and should definitely get their vaccines. It is still open to the general public. That's not the case in some other provinces where the funding cutback at the provincial levels have already excluded many individuals from getting the vaccine if they can't pay for it themselves. So I'm happy to take any questions now, and sorry for starting late.
Thank you so much, Victor, for the presentation. We do have two questions in the Q&A. First one of them is, sorry, you might have missed it off the start, but was there a disclosure of conflict of interest? And there was a slide in that.
I can go back to that slide. The COI disclosures. Do you want me to go back to the slides, or you want to just have the slides there and send out after?
That will be available in the video, but yeah, if you're able to share your slides, we can share them with the participants here as well.
You can still see the screen?
Yes.
Okay.
Thank you so much. The second question here is, will RSV be funded going forward given all the recommendations and support from various groups?
So there's two different approaches. We know that in women, individuals who are pregnant, they don't have all the options available. There is the passive immunization, and then there's active immunization. The nirsevimab program is disparate between all the provinces, among the provinces. Some provinces have it funded. In British Columbia this year, the BC CDC is using the scoring system, which then also makes it less available for people who don't strictly meet the scoring. This is different than other provinces that have fully funded it. Similar for RSV vaccines across the different provinces, the criteria are different. And the reason for the differences in criteria isn't because they are reviewing different scientific literature. It's purely how much Treasury Board in each of the provinces have to fund the vaccines. So I can't answer that question about whether it's going to be funded in British Columbia, because that would be a Treasury Board decision.
Okay, thank you for the answer. Are there any other questions from the audience? And Victor, you mentioned before that you wanted to compare and contrast the practices in hospital and in community pharmacies.
Say that again about hospital versus community.
You mentioned before that you wanted to compare and contrast some of the practices.
So I don't know about community practices. It'd be great to share what tips you have. In hospital, when we promote Prevnar, the conjugate pneumococcal vaccine that's publicly funded, influenza vaccine, and COVID vaccine, there have been different approaches. During the COVID, during the first couple of years, our hospital pharmacists played a key role in vaccine uptake, consenting and ordering the vaccines. That role now has kind of taken a step back because there are so many other vaccines that patients in hospital should be opportunistically offered. And so with PCV20, it really depends on the service, how busy it is. If they are admitted on our team that might overlook it, it might not be ordered. So even in ICU, where we have people with invasive pneumococcal disease, when we round, we often just bring it up to say, they've had invasive pneumococcal disease with a certain serotype that we're not going to find the answer to until retrospectively, several months or a year from now. So we should prevent or reduce the risk of a recurrent invasive pneumococcal disease with different strains of vaccinating. That requires someone to just order it, and it's easy in hospital if someone orders it, but if they don't order it, that's a missed opportunity. Similar for influenza. Whereas for the unfunded vaccines, the only group in hospital where we can get coverage for is First Nations elders who are over 60 years old, or those who have First Nations health benefits that have a comorbidity. And the process there is a bit more labor intensive, because not only the consenting part and discussion part is not challenging. The part is ordering, because hospitals don't have non-formulary drugs. And so as a vaccine, because it's not public health funded, we have to order it using our electronic health records. Then we have to print the order, fax it to a community pharmacy for them to ship to our hospital. Then the orders sometimes aren't given because the patient's just discharged by the time it arrives. Or a nurse might cancel the order because there was no vaccine available when they saw the order. So a lot of challenges logistically. And then if someone is not covered, or is covered under Plan W, under First Nations Health Benefits, but is under 60 years old and they have a comorbidity, it's another form to fill out. However, that form turnaround time varies. Sometimes it's within a day it gets approved, and sometimes we've had cases where it took 2 weeks before approval. And then so when the vaccine was sent to our hospital pharmacy, 2 weeks later, the person's already left. Fortunately, in this case, the pharmacy was willing to take the vaccine back, given the circumstances of the delay in approval, delay in shipment, and in this case, because it satisfied the cold chain criteria, they were able to take it back. So I'm just wondering, in the community, do you have any suggestions on how we could make this system easier for hospital and also for patients themselves?
And feel free to drop your comments either in the Q&A or into the chat, or raise your hand and then we can unmute you. You're always also welcome to comment on anything that we have in these webinars to our generic email, and then we share those comments with our team members and our presenters like Victor. In this case, there is a comment though for the RSV vaccine. Got some info from HealthLink BC website, and FYI, the RSV vaccine is not free in BC. Some private health insurance plans may cover the cost of the vaccine, so be sure to check with your insurance provider for details. Any other comments or questions from the audience?
The cost of those vaccines are high, and if I were to make us and we are doing advocacy for this, in that if Canada had a Canadian vaccine program, similar to a concept of Canadian Blood Services, I think the cost of vaccination programs would go down because of mass purchasing, better logistics. But right now, it's so fragmented that even within a province, how vaccines are then delivered, procured, adds to the administrative costs. And so the federal, provincial programs for vaccination is not working. It's costing the Canadian healthcare system more than if we had a more centralized program, similar to something like Canadian Blood Services.
And there is another question in the chat. Do you have a preference for a particular RSV vaccine for those 60 plus, perhaps one that has been proven safe and effective in pediatrics?
So in the pediatric, I actually can't speak to the pediatric data because I work in the adult infectious disease side. I would have to look at that. As far as I know, most of the pediatrics recommendations don't apply. Possibly if they have comorbidities, I'd have to look into NACI for that. I can't make a specific recommendation of one over the other, because as far as I know, the cost is the same. One does have 3 years worth of data versus 2, or 3 seasons worth of data versus 2 seasons. The clinical trials in which they were studied looked at different outcomes, so I can't rely on the efficacy numbers to help with that, making that decision. So I think in the end, as long as we explain to clients that there's 2 available and these are the key differences, I think they choose what, I guess they end up choosing which vaccine they take if they're willing to pay for it, or if they have coverage. Oh, sorry, one group does have coverage that I didn't mention is this year, the First Nations Health Benefits has made it easier for those individuals who are pregnant between 32 and 36 weeks. Previous season, individuals had to pay for it out of their own pocket and then get reimbursed. Now it's run through the Plan W and Blue Cross with the First Nations health benefits. So if they qualify, they don't need to pay for it. It could just be billed through the Blue Cross program. They just need they just need to be on Plan W.
Thank you. There is one more question here in the Q&A. Based on the limited data for RSV and hospitalization, ICU visits, and the unknown duration of efficacy, I find patients are reasonably reticent to purchase it. Do you have any thoughts on this?
Yeah, so it's good to point out that when those studies were done, that was still done at a time when many places had COVID protection measures. And as a result of that, the numbers, the hard outcomes of hospitalization was too low to be able to say, you know, we were able to decrease hospitalization. What's happened since then is the real world efficacy data of in, for example, US, some of the healthcare systems have shown their data and their insurance coverage groups showing the protection against severe outcomes, hospitalization and death. So although that data is not the clinical efficacy from the randomized controlled trials, that could also be additional information that someone might consider when deciding or not whether they want to pay for the vaccine.
Okay, thank you so much. Are there any other comments or questions? All right. Thank you so much, Victor, and thank you so much, everybody, for joining our webinar today. It will be posted on the BC Renal YouTube channel. You can always find it under our series in the playlist there. And stay tuned for our upcoming future webinars. You will be receiving the information through the usual channels. And there are a couple of things in the chat. Thank you so much for this presentation. Very informative presentation. Thank you. And that's all. We will end here. Have a great rest of the day.
Thank you. Please download the poster, make at least people aware that this is endorsed, at least the influenza, COVID, and pneumococcal vaccines for your patients from the different health authorities and through BC Renal program. Thank you. Have a good day.